Ciao mondo, hello world, hola mundo, hello mom, konnichiwa, ni hao. We're here today at the International Renal Research Institute of Vicenza taking a cappuccino, and I was reading this paper entitled Nonvitamin K-dependent oral anticoagulants, NOACs, in chronic kidney disease patients with atrial fibrillation from the Lullo and co-workers, published in Thrombosis research. So this is the paper. It is important because atrial fibrillation represents the most common arrhythmia in patients with chronic kidney disease, and as in the general population, in chronic kidney disease patients, atrial fibrillation is associated with an increased risk of thromboembolism and stroke. However, in CKD patients, especially those on renal replacement therapy, they have also an increased risk of bleeding, especially from the gastrointestinal tract. So, while oral anticoagulation is an effective management in patients at risk of thromboembolism, both chronic kidney disease and normal patient with atrial fibrillation having an increased risk of stroke, we have limited evidence of efficacy of some specific therapy in CKD. There are also some concern regarding the use of warfarin in CKD, often resulting either in underuse of anticoagulation or misuse of anticoagulation with the complications. There is a large body of evidence that suggests that NOACs significantly reduce the risk of stroke, intracranial hemorrhage, and mortality, also reducing the major bleeding complication when we use NOACs. This should represent, therefore, a very recommended therapy in patients with atrial fibrillation at risk for stroke. However, NOACs metabolism is largely dependent on the kidney elimination, and little is known in patients with the creatinine clearance less than 25 milliliters per minute, who are normally excluded and were excluded from all pivotal phase 3 NOACs trial. So this review is important because it describes very well how is the metabolism of the different NOACs, and especially at the end there is a wonderful table in chronic kidney disease dividing patients with a GFR between 30 and 49, in which the first choice is apixaban with a reduced dose of 5 or even 2.5 milligrams twice a day, while rivaroxaban and edoxaban also should have a reduced dosage. There is a second choice with abigratan, and finally, not recommended the NOACs at the full dose. In patients with less than 15 milliliters per minute of clearance and GFR, practically there is no indication for NOACs, although in United States, FDA recently approved the use of apixaban in hemodialysis patients. So I think this is a very important new area of investigation, and we have to collect more and more information. I think it's important for you to read this review of NOACs in chronic kidney disease patients. And with this, thank you very much for joining today, Cappuccino. Don't miss the opportunity to get more information on this important topic.